Good evening, everybody. I've had Vicky on there a few minutes ago, and her electricity has just gone. So we're just going to give her a couple of minutes to come back in. Apologies for that, but please do stay with us because we have a very exciting webinar this evening on zygomatic implants. Just while we're waiting, I just thought I'd share for you for anybody that's in the Northwest. We have this course coming up, your appointment 360, and it's called Mastering the Modern Preventative Appointment. So we're delighted to join up with Jamoki, and Lauren Long and myself are going to be running this course. And your 360 appointment, we're going to be going to different areas. And really, we're looking for ideas from you about what you would like to be involved in a day course. So this one involves like periodontal examination. We're going to look at using digital and voice notes and so on. We're going to include lifestyle medicine, behavior change, coaching approaches. Of course, we always have to have the hands-on. But also, what about, when patients are not responding? What do we do about that? And what's the referral pathway and so on? So really nice interactive day. I'm really looking forward to it. And like I say, we're going to go to other areas. So if you have any ideas around what you'd like for us to include in the day, we're really open to that. So I'm going to put the email into the chat box this evening and you can let us know. I'll just show you the timetable for that there, if you can see it. But keep an eye out on the socials anyway for that. I'm just going to stop the share there for a moment. Lots of other webinars coming up. We've got Varkaratu coming back, and we're going to get some panel discussions, particularly one around air polishing. We'll get asked about that so much. Again, if there are any topics that you'd like us covering, we're getting the autumn program together, please just let us know. So I'm just going to go and check on Vicky there, and we're just going to give her 5 minutes just to get back on. Thank you very much. Thank you, Vicky. I was just letting everybody know your electricity went, but you're back on and everything's fine. And that's technology, isn't it? That's the way it goes.
What a silly day it's been.
Uh, well, we're all here ready, waited. Take a deep breath, and that's the world of technology, and that's what happens, and we all completely understand. So we're only 5 minutes, so it's not too bad at all.
Oh, thank you, everybody, for having so much patience with me.
Not at all. Not at all.
I've got to learn how to share this now, so let's
Yeah.
have a look.
So the ribbon, there's just a little green square. Yeah, there we go. Yeah.
Let's delete that. Sorry, 1 second. Cancel that. What's that?
That's it.
I think
The present there at the top right. Yeah.
it's not coming up the way that I need it to. Uh, just let me stop it a second because Catherine showed me how to do this yesterday. Here we go. It's just what you need, isn't it, after a long day at work?
Absolutely. Absolutely. We totally understand.
Right, perfect. So can everybody see that?
Yes, we can. Thanks very much, Vicky.
Perfect.
I'll leave it to you.
Thank you so much, everybody, for your patience this evening. So my name is Griffiths, and tonight I'm going to be presenting a lecture about zygomatic implants and how we look after our zygomatic implant patients. So, just a little bit about me. Before I was a dental therapist, I was a former acting senior dental nurse at Manchester Dental Hospital. I used to work with the implant placing dentist at Manchester, and I absolutely loved being an implant nurse, hence the reason I probably do it now as a dental therapist. I've assisted surgeons as a dental nurse and as a dental therapist who place zygomatic and pterygoid implants. I graduated as a dental therapist in 2019, and I currently work between a private referral hospital, which is ICE, and a private dental practice, where I carry out things such as hygiene appointments, and I also treat paediatrics and I carry out inhalation sedation. And I'm currently at BSDHT Northwest Regional Group Rep, and I was involved in the S3 peri-implant disease and its management from the BSP abdomen working groups, which was very interesting to say the least. So, before we begin this webinar, I just want to tell you that it's going to equip you with a little bit of knowledge about zygomatic implants, but it's not going to give you all the tools to go out and treat zygomatic implants. Zygomatic implants are so complex and they require collaboration with an experienced implant dentist. Zygomatic implant maintenance is typically handled by the placing surgeon in most places. A lot of dentists, rightfully so, really, because this work is such high value and it's really complex surgery, they will want to manage and maintain their own zygomatic implants themselves. And obviously, if that's not the case, there's things that you should be doing, which I will talk about now. So, when I first started seeing zygomatic implants about 3 years ago, um, I actually had a team discussion with the placing dentist, and we sat down and we set up a protocol with a step-by-step approach to how I would be assessing the zygomatic implants, when I would need to refer things back to him, and we work in really close collaboration. I mean, I've had a zygomatic implant patient in today, and I noticed there was something on his prosthesis that I needed guidance with. And he came in from his surgery, what he was carrying out, and he came in and he looked at the patient. And it's just that teamwork, and you need that close collaboration with these implant placing dentists, because if you've not got that, I would feel very isolated and I would not touch these implants at all. So I'm just going to show you a couple of images, and then we'll talk about how we know there's a zygomatic implant there. So when we look at this image, would you automatically know if there was or there wasn't a zygomatic implant placed in this patient's oral cavity? And this is the same patient. Again, just from looking at this image, would you be able to see that this patient had a zygomatic or they didn't have a zygomatic? And again, same patient, different image. And the answer is no, we wouldn't. A radiograph is really the only way to detect non-conventional implants. And as you can see, this is a unilateral zygomatic implant, and this patient's got a little pterygoid implant there as well. and some conventional implants scattered all around. So zygomatic implants can be placed in either unilateral, bilateral, quad zygoma. You can have pterygoid implants, which we've got on this patient. They've got quite a mixture of everything, this patient. We've got some zygos, some pterygoids. I hope you can all see my mouse moving. We've got a little floating conventional implant here at the top, and we've got a bare conventional implant here. Now, these bars are usually used in patients who haven't got a lot of bone in the mandible, and it just gives the prosthesis a little bit of stability. So this is just a little picture just to show you the difference in size between a conventional implant size, what we're going to be treating in dental practice and maintaining and managing, a pterygoid implant size, which is somewhere kind of, and a zygomatic implant size, which are absolutely huge. I'm saying that, it's about that big. So yeah, you can tell the stark difference between the conventional and the zygomatic. This is just a little 3D. Putting this in my presentations. I think I stole it from my colleagues. And as you can see, these zygomatic implants, they only have threads, some of them right at the top, and this is where the osseointegration is actually there. It's in step comparison to our conventional implants here at the front, where we know osseointegration is where the crestal bone is. Good. Let's move along. And we're here. So if anybody's eating the tea or dinner, I call it tea because I'm from up north, please just look away now. So as you can tell, this is a major operation. It's for experienced implant surgeons only. Your general dentist who's done a 2-day course at the weekend can't just go and start placing zygomatic implants. It's usually your implant placing dentists who have been doing this for many years, and they've placed other conventional implants first, and then they move on to place the zygomatic implants. As I was just mentioning, the different systems of dental implants, we can see that there is some differences between them all. I mean, these dental implants here have got a smooth head. Some of the dental implant systems have actually got micro threads at the end, because some of the dental companies think this helps aid osseointegration, which doesn't really make a difference, neither here or there. My placing dentist who I work with, he prefers to fit the flat-headed ones, because they don't act as much as a PRF, so like a plaque retention factor. So they're usually flat, polished surfaces. So zygomatics can be either placed by a 2-stage or an immediate loading protocol. Both have good success rates, but studies do show immediate protocols have less infection rates, less discomfort for your patient, and there's also a greater survival rate with about 98%. We generally do at my dental hospital, we place the immediate loading, but in some cases, the professor will actually do it in a 2-stage, depending on why that patient is having zygomatic implants in the first place. And just at the bottom, you can see here, the zygomatic implant is either placed directly into the sinus, we call this an intrasinus, or it can be placed underneath the maxillary sinus. And again, that all depends on your patient's anatomy, the reason why they're having this implant placed in the first case. There's a lot of considerations to make when these patients are going through this surgery. It's not just turn up to your dentist, have a review, have an x-ray, and then you can go in and get your zygomatic surgery. It's a long, drawn-out process, and there's lots of medical history questions that need to be asked. You've got to get different scans, so both intra and extraoral scans, and the patient's got to be prepared for the surgery as well, because as we saw on this slide, this is just not a surgery that anybody can do. It's very intense surgery. The patients who are at our practice, they always have sedation. So we always have an anaesthetist on site and a general nurse as well. to manage that patient while they're sedated, because it's usually a mixture of sedation drugs. So it's not something that can just be done in a general dental practice. You've got to have all these protocols in place and all these special people present as well. So after we've done this surgery, things can go wrong. There is a few complications that can happen. So things like a soft tissue dehiscence, sinusitis, and also prosthetic fractures. So this is one of my patients who was also seen by one of my colleagues previously. She hasn't really taken on board the advice about smoking. Now, she has actually quit smoking now. She's no longer a smoker, but when she first got her zygomatic implants placed, she just carried on smoking, which we totally said, no, you cannot do this. It's not recommended. The surgeon won't even place zygomatics in patients who are vapors at the moment. So it's really important that these patients are listening, else things like this happen. Now, with this patient, we take photographs every time she comes in, and I've monitored this for the past 3 years. And me and the professor are really happy that this is stable at the moment. But obviously, you can't really see it when she smiles. She is aware that this dehiscence has happened, but there's nothing really much we're going to be able to do about it at the moment. We just keep on monitoring it and making sure our oral hygiene is really top notch, and hopefully it stays that way for a long time, and we don't have to do anything further for her. So, zygomatic implants can be placed alongside your conventional implants, as we've seen on the radiographs. They can be placed with pterygoid implants, or they can just be placed as a quad on their own with no additional anterior support. What the dentist is thinking of before they're placing these implants is they're thinking about the patient, they're thinking about the little bone they've got. They need good AP spread. So AP spread stands for anterior, posterior. They need to make sure they've got that really good spread for the patient, so the occlusion is good and everything else that falls into it. Sometimes they can be placed alongside implants called nasalis implants. These implants are the ones that are placed in about the premolar region, and they go in the bone, the dense bone, which is between the sinus. So these can add really good anterior support if your patient hasn't got much bone at all. And this is just a lovely radiograph. This shows a little bit of everything like my previous one did. So we've got some pterygoid implants here, we've got a quad zygoma here, and we've got some conventional implants on a bar here at the bottom. It's really important when we are looking at these radiographs that you can see that osseointegration isn't happening where your conventional implant osseointegration is happening. It's usually happening up here in the zygoma area. So it's really, really important that we're understanding this, because they are not conventional implants. They're not conventional implants compared to the conventional implants, if that makes sense. And a CBCT is recommended 1 year after surgery. I did get permission to post this CBCT because it's mine. As you can see, I don't have any zygomatic implants, but I just wanted to show you that this is what a CBCT looks like. This is something I can take for the patients if prescribed by a dentist, and you should only be doing this under a prescription from a dentist. You shouldn't just be deciding to take a CBCT for your patients because they've got zygomatic implants. That's not our place to decide. That is the placing dentist's place to decide and prescribe to you. So we can take them as dental hygienists and therapists, but only under the prescription of a dentist, and they dictate what kind of CBCT we take. So what are the indications for zygomatic implants? So severely atrophic and dentulous maxilla, previous oral or facial cancers and tumours, previous disease or failed conventional implants. In the case of the patient who you saw before with the soft tissue dehiscence, that patient actually had conventional implants before she had zygomatics, but due to a history as a smoker and other factors, they actually failed. So it was decided, and again, they had a big meeting, a few sessions, a few exams with the patient, CBCTs, scans, extraoral, intraoral, and then they decided that that was the best way to go for that patient. And also patients with cleft lip and palate. I've got a cleft lip patient who's got a zygomatic implant, and it's just totally changed their life. It's amazing. So they're a really, really good addition to our practice, really. And they're becoming more and more common, which we'll speak about in a little bit. And what are the contraindications? So obviously we know patients who smoke, it's a contraindication for them. Patients with a history of chronic sinusitis, maxillary or zygomatic bone pathologies. This again will be picked up by the surgeon who will analyse the CBCT. If they see anything suspicious on the CBCT, they will get someone who's radiographer trained to report on that CBCT. We usually send ours out to an external company. I'm not sure what everyone else does in the practice, but that's what we do if it's a CBCT or an OPG with things on that shouldn't be there. And uncontrolled malignant systemic disorders. So before I even look at my patients intraorally, here's a few things that I ask my patient when they sit down in my chair. And sometimes these appointments seem to take forever. Usually I have about 45 minutes for my zygomatic patients. That's just something, again, I sat down with my professor and discussed that I'd need extra time. For some of my conventional implant patients, I usually have about 30 minutes, depending on what the patient's in for. But Zygomatic is always 45 minutes or sometimes more if they've had issues or problems previously. So I sit down and I have a chat with my patient, see how they're doing. And if I've never met this patient before, it's a new patient to me, I find out when the implants were placed, why they were placed, how long ago they was placed, and any previous maintenance protocol, either with the placing dentist or with a hygienist elsewhere. I also ask my patient if they've had any episodes of sinusitis since the placement and if they required antibiotics and any previous issues such as any facial pain. That's all important to know. I've actually got a template for my zygomatic implant patients. So it's something that I've got all my headings and then I just add in everything that the patient says. And it just makes my life a little bit easy because we do have to ask these additional questions with these patients. I also ask if there's been any changes in the oral cavity with the patient, so things such as halitosis. And this question is particularly important for diagnosing potential rhinosinusitis, which can then impact the zygomatic implants. So, what do we do in our assessment? We take photographs. I take photographs every single time my patients come in, and they end up on. We use Dentally at my work, and we end up with so many pictures on the Dentally, but it's something that I can refer back to. So, things such as those soft tissue dehiscencies, I can think, right, this patient came in this year, there was nothing there, and now they're presenting with this. Where did we see this? Was it visible on this visit? And it just gives us that kind of aide memoir so we can look back on our patients. And it's also good for the patients to see as well, to see how things have either progressed or in some cases not progressed. And we monitor changes in the tissues as well. So it's really important that we're doing that at each and every visit. So we do a tissue examination. So when we're doing our tissue examination, we're checking that there's no erythema, we're checking there's no edema, we're checking the contour, we're checking if there's any blanching from the prosthesis, if the prosthesis is really, really tight, making sure that there's no blanching in any areas. And we're checking for any other soft tissue presentations as well, so things like fistulas and obviously, we're checking things what we checked before when we sat our patient down. So we're checking the patient's tongue, seeing if there's any discoloration on there. All these things all form a picture for us when we're treating these patients. And again, this is just me doing a soft tissue examination. This patient did give consent. In fact, he was absolutely chuffed to bits that I was putting him in this presentation. So I got consent signed and scanned onto his lips. So we're going to be doing a sinus examination. So sinuses should be checked on zygomatic implant patients extraorally. So I usually start off by gently feeling the patient's face, and I think I have got a video here showing me doing that. Hopefully it plays for you. So this is just what I do when I'm doing my sinus exam, and what we're checking for is we're seeing if the patient's getting any pain when I'm pressing gently on that area. I do generally do it for a little bit longer than that. This is just for the purpose of a video, for a demonstration for you guys. And we're checking for any tenderness as well. So all in this maxillary sinus area, we're checking for tenderness on palpation when we're doing this exam. We're also going to be carrying out a TMJ check, so temporomandibular joint check. Now, I do carry these out on my patient because I actually, when I was at university, when I was doing my diploma, I did a few sessions at the dental hospital on a TMJ clinic. So I do feel confident doing this. Now, if you're a clinician and you've not had this training or you've not done this for a while, maybe it's worth sitting down with your dentist and seeing if you can just go in and shadow a few sessions with the dentist doing this, and you can kind of be able to do it in your own practice. But if you don't feel confident doing it, just please ask the referring implant placing dentist to do this for you. And we're going to be palpating. So just like a conventional implant, we're going to be palpating around these implants. We're going to be looking for suppuration. We're going to be looking for any signs of infection. We're going to be looking for bleeding. It's also important to palpate the lymph nodes for the patient. And as it's already been mentioned, it's important to really palpate those extraoral sinuses to detect any early signs of the inflammatory process around the implants or the sinuses. We're also going to be checking our prosthesis. Now, this is really important because we're looking for defects which could potentially act as PRFs. So things such as loss of composite covering around the access screws, which is really common. That's actually something that my patient, my zygomatic patient today had, why I needed to call the dentist in, because just a little thing like this can really affect our zygomatic implant patients. We're going to be checking for mobility. We're going to be doing this vertically and horizontally. We're going to be checking for biofilm around the multi-unit abutments and also the prosthesis. For all my zygomatic implant patients, I usually disclose them to make sure that they are brushing correctly. The oral hygiene needs to be impeccable. There's no ifs or buts about it. I do intensive oral hygiene clinics with my patients to make sure that they're armed and they're ready to go with their oral hygiene before the zygomatics are even placed. And as soon as these zygomatics are in there, they book straight back in with me. And we go through all the processes, all the different things that they may need. But plaque disclosure is really important part of my zygomatic implants and what I do on these patient visits. We're also looking for defects, looking for things such as the contouring of the prosthesis, the design of the flange, and all these things are really important to mark in your notes because these are all things that could cause an issue further on down the line for the patient. We do not probe zygomatic implants. So when we probe a conventional implant, we're checking for inflammation. That's why we probe it. Now, one of the parameters we're looking for is loss of crestal bone, and you can detect this by feeling the threads, and that will tell us there's been some loss of integration. Now, as I've already mentioned, integration for zygomatic implants happens in the zygoma. So we're not actually going to get anything of clinical gain from probing these implants. They're also really unique in the fact that obviously the length is different, the inclination's different, the position is different, and the relationship with other bodily structures such as the sinuses. So it's really, really important you do not pick up your probe and push it in to where these zygomatic implants are. It's a complete no. But we can, if I get my next video, we can gently sweep the gingival sulcus or the gingival tissue, sorry. So you can kind of do your Montbelli modified sulcular bleeding index, so where you'd gently go over your gingival tissues and mark anywhere that's bleeding. We can do this for our zygomatic implant patients, but let me just play this video again. You can see that that probe does not go anywhere up that gingiva. It's used horizontally. We do not vertically push that probe up those tissues because, as I've mentioned, there's nothing to gain from this. And we can actually cause something what we call an OAC. So an OAC is an oral-antral communication, and that's like a pathway that we can create from the patient's oral cavity to the sinus, which is something that I definitely don't want to be creating for these patients. I want to create something, but not a communication. We do not polish zygomatic implants. So many people, if you don't know that your patient's got a zygomatic implant, will just pick up the air polisher and just go happily all around these prostheses. Now, again, this soft tissue around these zygomatic implants is really, really delicate. And the proximity with other sensitive extraoral anatomic structures and your risk of surgical emphysema, your risk of oral antral communication is just so high that we do not use air polishing. If you've got biofilm around a zygomatic implant, what you can visibly see, pick up your Oral-B test drive. That is something that will remove that biofilm. Even after you've done a plaque disclose and you can get that biofilm off with that, you should not be using an air polishing device around these structures. We would also not recommend water fossa for exactly the same reason. It's just something that I don't recommend for any of my zygomatic implant patients. Usually the implant placing dentist who I work with, he kind of designs the prosthesis that goes on these zygomatic implants, and he designs them in mind that we can fit oral hygiene aids either underneath them, around them. So yeah, it's really important that we know that we're not recommending this. So what can we do? Because I've talked a lot about what we can't do. I'm just going to show you some videos of what every implant patient of mine gets demonstrations of. So our test drive. This is something that is hopefully in everybody's dental surgeries. If not, reach out to your reps and then they can get you some in. Full arch prosthodontic structures do not resemble natural teeth at all. They're really bulky sometimes and can be really challenging to clean, especially in your lingual areas and your palatal regions. So it's really, really important that we're re-educating our patients, and it's going to be intensive. We've really got to push this home that this is something that they've got to do for the rest of their life, because we hopefully hope these implants don't fail, because there's not much else after zygomatic implants. We're also going to be showing our patients how to use a sulcular brush. This is something I absolutely love showing my patients how to use. These sulcular brushes are really, really soft, like baby toothbrushes. And what they do is, if you've got a bulky flange on your prosthesis or the whole prosthesis is quite bulky, these sulcular brushes will just get underneath and they'll clean all that biofilm. Again, this is really good to demonstrate to your patient after they've had the disclosing agent on, and it'll just show them how easily we can remove all that biofilm. Incidental aids, if possible. This is an icon brush. I don't know about anybody else, but I've been trialing the new TP brushes, the Easy Fits, and I absolutely love them. I'm finding that my patients are really liking them as well. Obviously, they are quite new. I mean, we've only just started getting them in the practices where I work in the last, I'd say, month or so. But I'm actually really, really liking the TP Easy Fits, because instead of the classic cylindrical shape of your normal interdental brushes, the conical and the bristles are a little bit softer. And that's really good for your zygomatic patients as well, if they can fit these brushes in that area. Because the bristles are really nice and soft, but they're effective as well at the same time. So if you've not got these yet, I think I got mine off Amazon. I'm not sure if any dental companies are stocking them yet. I'm sure there will be, but I got my first lot off Amazon. So just a little tip for you there. And we're also going to be recommending which is a sulcular brush, or I call these a single stick brush, or an implant brush. I just call it anything as long as it actually works for the patient. I've demonstrated it to them in the mouth. It's really nice to use over your flange, and you're just telling them to paper it, and it's really, really nice to use over the where the implants are placed. Now, this is a bit of a sad post, because I'm going to show you this video And I don't really use Exos much anymore. Let's go back to the beginning. Sorry, it's not showing that. I don't really use Exos anymore because I really struggled starting to get hold of it off my usual wholesaler websites. And then one of my colleagues told me that the company had been bought out. So we can't get hold of it at the moment. So I'm absolutely devastated because I love this stuff. Obviously, it's for patients with healthy implants. We wouldn't recommend it around patients with diseased implants because the little bits of it can fray. But for my zygomatic patients, I absolutely love recommending this. I used to tell them to dampen it a tiny little bit so it wouldn't fray as much. But yeah, I can't get hold of it anymore, so I can't recommend it. Yeah, so I'm just really sad seeing that post. And another important step for zygomatic implant patients is to make sure that they are maintaining their sinus health. Now, this is something that not everyone will realise that they need to do for the patient. So, as a chronic sinusitis sufferer and someone who will probably never be able to have zygomatic implants, these are something that are in my bathroom cupboard all the time. So, I'm really, really good at recommending ones for patients. This should be performed as part of a maintenance program. Obviously, we don't do it for the patient in surgery. We just can advise the patients which ones are good. These are the ones I recommend, and I just recommend that they do it maybe once a day, twice a day, in the morning and at night time, just to keep those maxillary sinuses moisturised. And as you can see, this is from an old paper as well. It's from like 2006, but from the papers that I've read, the guidance hasn't changed much. So this is what I still recommend to my patients currently. And formulating recalls. So every single one of my zygomatic implant patients has a 3-monthly recall. It doesn't matter if they're brushing 100 out of 100. It doesn't matter if they're a star patient. They still come every 3 out of 12. So that's just that. And they know that from the assessment appointments that they are having with the implant placing dentist. He actually tells the patient that they'll be a lifelong patient of mine as well, which is always nice for the patient to know. Obviously, these protocols I did with my implant placing dentist, and it's something again that you would sit down and discuss if you are going to go into practice or you're in a practice what's currently doing this at the moment. If you detect disease, we increase our frequency. If I detect disease around a zygomatic implant, the first thing I'm going to do is get that professor in straight away. I'm not going to send the patient away. I'm going to get him in that surgery if possible on that day. And again, that's one of the benefits of working in such a team that's really close and works side by side. And it's that collaboration what makes things a little bit safer for your patient as well. And periodic removal may be required. Now, this is something that we don't do at ICE currently. We don't remove any prosthesis, or the implant placing dentist doesn't remove any prosthesis unless we've detected suppuration, unless there's profuse bleeding. I have got a slide about this in a second, so we shall talk about it in a minute. And a lovely plane there. I've not seen one of them for a while. At ICE, we don't recommend that hygienists and therapists should be seeing any implants direct access. Again, I work under the professor. We've not, if you work in direct access and you're seeing zygomatic implant patients, you've not got a provision for collaboration with your implant placing dentist. And this is massively important when you're seeing zygomatic implant patients. I have noticed a massive trend at the moment. I don't know whether it's a good thing or a bad thing that I'm part of a group where people travel abroad and get the teeth done. All different kinds of countries, not just the classic one. There are many other countries people go to get these implants placed. They're going getting zygomatic implants placed. So we're seeing a lot of zygomatic implants being placed in a lot of younger patients. I don't know how I feel about this. There must have been a reason why the dentist placed them. I don't know, but we are seeing a rise in this. So it's important that when you're getting your full arch patients in, that you're checking radiographs. you can't just get away with taking a periapical. It needs to be an OPG if you suspect that the patient's got zygomatic implants. Now, a lot of the times people will know they've got zygomatic implants placed because they have gone through that massive surgery and they've gone through all these appointments beforehand. And sometimes people are just oblivious to it and they don't even know. So that's the importance of asking all these detailed questions with your patients, and just making sure that you've got all your facts covered and you've got all your crosses ticked or whatever the saying is before you start picking up your polisher, picking up your hand instruments and digging around these implants. And the importance, again, like I said, of the collaboration with your implant placing dentist. So I just thought it was important to put this statement in. So this is Straumann's position and statement on periodic removal of conventional implant retained fixed prosthesis. So conventional. So this is not zygomatic retained prosthesis. This is just your conventional implants. Some surgeons do remove zygomatic implant patients' prostheses to assess tissues. These are your zygomatic implant placing surgeons who are doing this, who are maintaining the zygomatic implant patients themselves. So they decide when and why they remove prosthesis. As I said, in the practice where I currently work in the hospital, we don't routinely do this. It's not something that is commonplace unless we detect disease. So again, I really emphasise this point, and I know I'm like a woman banging a drum. It's really important you're setting up protocols with the person who is placing these implants. It's really important that you're sitting down and you're making them aware of, or they're making you aware, sorry, of things you should be doing and things you shouldn't be doing. Because high value work can easily go wrong, and it's just not something that I would want on my head, really. So it's very important that you discussing cases with your dentist, sitting down and looking at CBCTs with them, trying to understand things as a team. And this is the zygomatic implant paper where I have read all about zygomatic implant maintenance. Our professor at ICE is absolutely devastated that this came out because he wanted to be the first one to bring a paper out about zygomatic implant maintenance, but we got beat to it. So if you want to read more about zygomatic implants, if you want to have a little bit more of background knowledge about zygomatic implants, this is the paper that you need to read. It's really informative, actually. Even reading it to get ready for this presentation, I found out so many things, and like it's just like making you remember things that, oh yeah, there's that as well. So it's really important that you're keeping yourself updated, making sure you read these papers if you're going to be treating these patients as well. Because it's not like a conventional implant. Although conventional implants have their own issues, non-conventional implants have a lot of other consequences if we're not looking after them properly. And thank you for listening, everybody. I'd just like to say thank you so much to Ikigai community and NSK for allowing me, little old me, to speak on this topic that I'm really passionate about. And thank you for coping with me at the beginning when I lost all power to get on the laptop. So thank you, everybody. And any questions?
Plenty, Vicky. I'm going to let Catherine take over the questions. I'm just going to put up the QR code in a minute and put the link into the chat. Maybe put the questions into the Q&A and we can keep an eye on them there. And over to you, Catherine and Vicky. Thank you.
Okay, Vicky. So Sarah's asking, where can you get the sulcular brushes from?
The sulcular brushes I usually get from my favourite place, which is Amazon. Dental wholesalers do sell the sulcular brushes as well. I might have a link somewhere where we purchase ours from, so I can try and look for that and send it you, Sarah, if you'd like me to.
TP do them as well, and Vitus.
Not do
Curaprox, yeah, Curaprox and Vitus as well do them. So there's quite a few.
Are you okay? Just to stop
ones are
the
really
share.
good.
Would you just stop the share, Vicky, please? And I'll just put the...
Oh, sorry.
So you're all right.
So can you use GBT powder on the buccal surfaces for stain removal?
Oh, zygomatic implants.
Yeah.
I wouldn't use a nail polisher around zygomatic implants, even on the buccal surface, but that's just what me and the implant placing dentist discussed when we set out our protocol. Um, and I especially wouldn't use it if I wasn't confident treating zygomatic implants either, not even on your buccal surface, because it only takes a little slip of your wrist and you're in those danger zones. So I personally don't.
Okay, great. So going back to direct access patients, when you said about not treating any direct access patients, was that related to any implants or just zygomatic implants?
Zygomatic implants. I'd always want to work in collaboration with the implant placing dentist. If that happened to be someone who came from a country abroad, I would speak to an implant placing dentist at work before I even touch that patient. I don't know. I don't think I told my story. So basically, I'll tell it really quickly because I know everyone wants to get going. But I had a patient who I was seeing at ICE, and I actually said that she wouldn't be able to get conventional implant treatment because her oral hygiene was really poor and she wasn't engaging and she wasn't motivated. So this patient went and flew to another country and got zygomatic implants placed because she had all her teeth taken out. And she had a upper and a lower completely, just zygomatics on the top and conventional implants on the lower. She then came back to me a year later, and half of the conventional implants had disease. I took an OPG because she did actually know that she had zygomatic implants placed. So I spoke to the professor who I work with, and I spoke to one of my colleagues, Catherine, and we devised a consent form for this patient, what she would have to fill in. So it was quite a lengthy consent form. And it's not just something, I mean, I don't want to sound egotistical, but I'm really experienced. Like, I treat implants for over half of my clinical time. I work with professors. I did this when I was a dental nurse. I understand a lot about implants. I work with people who lecture on dental implants and have a lot of knowledge about them, and who I can fall back on if I need advice. It's not something I would ever want to be doing on my own, isolated in a practice without that team. And it's really important that you can't just go into zygomatic implants without having this massive team behind you. I just cannot emphasize that point enough.
Great. Um,
Can I just check that you can see the slide there with the QR code?
I can see it, and
Yeah,
hopefully everyone else
yeah,
can.
and I've put the link, so that's fine. I'll give it another minute. Just sorry to interrupt you, but just to let you know that anybody on this evening can have the education 40% off code. That's there on the slide, so you can take notice of that, and you can use that on the shop at any time. That's valid for the next 2 weeks. Thank you.
So, what would be your prophylaxis when the zygomatic implant has been removed? So the prosthesis, I would assume, has been removed.
So if your prosthesis have been removed, I mean, because I'm experienced at treating zygomatic implants, I would gently use, if there was anything present, like if there was any calculus present, I'd gently use a hand instrument around the zygomatic implant. Again, if there's disease present, the dentist who placed it would be treating it, not me.
Mm,
And I'd
great.
use a test drive because that's my best friend in clinic.
I think this has probably already been answered, but can you air polish horizontally to clean the prostheses?
I just, I'm I'm a stickler for the rules. If anyone knows me personally, you know I'm a stickler for the rules. And again, like I said, working with people who are very experienced in implants, I'm always kept in line as well. So no, I don't divert away from the standards that my implant placing dentist has set. I do not use polishing devices around zygomatic implants at all.
Do you feel like I'm getting a bit of a bad rep here?
I
Kept
think
in
you should be
place.
quite flattered. I
Kept
think
in
you should be
place
quite
though.
flattered.
Um, and Another question, are pterygoid implants treated differently or are they the same as conventional implants?
That's a really good question. Pterygoid implants are treated the exact same as conventional implants, so you can use your air polishers around them. You can use exactly what you would use around a conventional implant. Also, your nasalis implants, you can treat them exactly the same as your pterygoids and your conventionals. It's just your non-conventional, i.e. your zygomatics, that you should not be treating the same.
Sometimes in my experience with pterygoids, they're quite difficult to probe. You can really only probe superficially because they sort of go
Under
off
the
at an angle.
angulation.
So even though there's
Yeah,
crystal bone support, that the angle just makes it really difficult. So you do tend to end up doing, your Mombelli rather than like
yeah.
an actual sulcular bleeding score. Just my experience. So on to the next question. Which, if any, ingredients do you look at or do you avoid in a toothpaste and mouthwash for patients with zygomatic implants?
That's a really good question.
Mm.
Obviously, we know there's a debate around fluoride, if you should or shouldn't use a fluoride containing toothpaste if you've got dental implants. I'm of the opinion that I don't really mind what the patient uses as long as they're using some form of dentifrice in the mouth. Um, I don't really recommend unless it's required a mouthwash, but I do like Blue M mouthwash. They also do a fluoride and a non-fluoride toothpaste for your patients. Technically, if your patient doesn't have any natural dentition, they don't have to use a toothpaste containing fluoride. I think that's just patient preference, really. I mean, the studies don't really show a definitive answer of whether it affects your implants or not. So it's just something that is patient preference. But I do like the Blue M range, and there's other dental companies as well that do really good ranges for post-implant treatment as well. I hope that answered your question.
I think it did, yeah. Great. Is the piezo okay on a low setting, supragingivally around a zygomatic implant if there is lots of mature biofilm and food debris?
If there's lots of mature biofilm and food debris around your zygomatic implants, you need to scale back your treatment from that patient, sit them down and intensively go through oral hygiene. You should not have a patient presenting, unless obviously you've never seen them before. There are instances where there might be, but if they're your patient, they should not be presenting to your clinic with food debris and biofilm around a zygomatic implant. Um, that should already have been handled before placement. No disrespect to you, by the way, whoever answered this question, whoever asked this question, because it could be a patient who's just walked in off the street. But no, I wouldn't use a piece on. It's something that I would speak to the placing dentist about, and maybe if he did require me to use something with power behind it, I would ask him actually to do it instead of me. These implants are very high value work, and they're just near so many anatomical structures that anything can go wrong. And it's really important that people know the limitations around these kind of structures as well. So no, I wouldn't use peas on at all. I'd use a test drive and a circular brush and an interspace brush to try and remove that debris.
Brilliant. Thanks, Vicky. Are you all right for a couple more questions? We've got a couple more.
I am, yeah,
Yeah.
yeah. I was a couple of
Um,
minutes late, so yeah.
so she's definitely a stickler for the time. Um, if a patient is booked in with me for zygomatic implants, having been placed elsewhere, no dentist to support in the practice, am I justified in not treating the patient and asking them to be seen at their placing dentist clinic just to confirm?
I would say you are justified. It's really as
Definitely
simple as
agreed.
that. You are definitely
Yeah,
justified.
definitely. I don't think that, yeah, you're right, and you've already said it in your presentation, haven't you? This is not something that we should be doing alone. Um,
I wouldn't be able to do it alone. And like I said before, trying to take ego out of this, I work in an implant place in referral hospital. I get patients referred to me, and I would not feel comfortable treating these sort of implants in an isolated environment because it would just not be for me.
yeah,
So you are absolutely justified and stand your ground
yeah, definitely.
if you need
Um,
to.
So, Annette had a patient today. I think it says. So I think it's saying had a patient today who had zygomatics in Turkey. She can't remember what the reason was, or she didn't catch what the reason was to not use a water pick. I'm assuming they've been recommended a water pick.
Oh,
So
sorry. What was the reason that we can't use water pick?
yeah, yeah,
So
yeah.
we wouldn't recommend a water pick for the exact same reason that we wouldn't use air polishers. Air polishers around implants, zygomatic implants, just because the gingival tissues are just so sensitive and delicate that a water pick or a water flosser is really quite powerful when you've got it on a high mode, and you could cause trauma, you could cause surgical emphysema. And I mean, I wouldn't want a patient at home to suffer from a surgical emphysema because they probably wonder what the heck was going on. They can also cause an oral antral communication as well. Sorry, I didn't
Right.
specify that in the lecture.
Oh, no, you did. I think you did. I think you did. It's just hard sometimes when there's lots of information coming at you, isn't it? Not for
Yeah.
you, but for the delegates, and they don't always catch everything.
Zygomatic
Um,
implants is a very heavy subject.
yeah, yeah. If a patient presents having had zygos abroad, do you refer straight to a specialist dental hospital? For us, dental hospital, I think. Oh, sorry. For us, dental hygienists who would not routinely see zygomatics.
I wouldn't necessarily refer to a dental hospital as such, or like a university dental hospital. Maybe ask your clinicians if they know of any dental implant practices close to you who do zygomatic implants. There are quite a few around each area. So people from the Manchester area usually refer to the professor who I work with because they know he places them and he actually mentors people for the Zygo Academy. I think he was president of Zygo Academy at one point, which is like a massive zygomatic community all around Europe. So if you know of any dental practices around that area, maybe a quick Google search, a ring around some dental practices. But that's possibly a better route than going via like a university dental hospital, I would say anyway.
Think that it's a good idea. You've talked about protocol quite a lot, and writing a protocol, and I think that's probably something that could be in a protocol that you've found somewhere that would
Yeah,
take referrals, and you know that
like the
patients
name and the
can go there.
number.
Yeah, yeah, yeah. Um, and then we've just got another one about water. It says water flossers can be used, right? I think that Vicky, you've explained that that's not the case. Yeah.
Yeah, we
Okay.
don't recommend the use of water flossers.
Great. Lovely. I think we are done.
Thank you
Yeah,
very
thank
much,
you,
Vicky. That
everybody.
was fantastic. Yeah, did everybody get the QR code? Oh, there is another question there.
Oh, is there? Well, oh, sorry, I'm not doing my job properly. Do apologise. There's two more now. Would you treat lower arch, for example, if there were natural teeth, but not treat the zygomatics on the upper? Recording
With
in notes advised patient to return to the placing dentist for these. I would assume that's return to the placement dentist for the zygomatic
and treat the
implants.
lower dentition.
Yeah,
Yeah,
yeah.
yeah. As long as you're not directing your air polisher vertically up towards zygos, I don't think there should be an issue with that. But yeah, as long as you're confident doing that, yeah, treat the lower dentition, but then refer on for your zygomatic implants. There's nothing stopping you if you do get a zygomatic implant patient in from going through oral hygiene advice. That is something that would be invaluable to a patient, and they may have not had that already, especially if they've had these implants placed in another country. Because obviously we need to think there's maybe a language barrier, especially in some of the countries where some of these people get them placed. There's not always an interpretation service. So yeah, giving oral hygiene advice, demonstrating test drive, how to use that around the prosthesis. That is something that you can do, and that as you're trained and you're qualified to do that. There is nothing stopping you from doing that on zygomatic implant patients. you shouldn't be held back from doing that. So if you do get a patient and you don't feel confident maintaining and managing the implants, I would definitely be going through oral hygiene with them.
Brilliant. That's great. You've got loads of people. Thank you for all the information. Very informative, useful presentation. Thank you so much. Really useful webinar. Fantastic webinar. Thank you so much. You've got absolutely loads of those, Vicky.
Yeah,
So well done. There's
I'm
another
really nervous, so
question.
it really makes me feel better.
Another question. Is there a need to perform local anaesthetic for OHI for zygomatic patients? If
No.
yes, is there a specific technique?
No, I wouldn't be giving local anaesthetic for any oral hygiene advice, instruction, sorry, and it's not something. The zygomatics are really comfortable for the patient, obviously, unless there's issues where we mentioned about the sinus checks and all the TMJ checks. The patient won't be in any discomfort. It'll just feel like a conventional implant, I assume. I don't have either. But from when I've spoken to my zygomatic implant patients, unless there's an issue or unless they've had an issue with occlusion or the prosthesis, they just feel really natural and it gives them a new lease of life. I mean, the patient who had the soft tissue dehiscence, I mean, she loves her life now. Catherine will guarantee and back me up on that, won't you, Catherine?
Yeah, yeah,
She,
yeah.
she's
She's
living her best life.
definitely is.
Just retired
Um,
as well. Lucky thing.
yeah, I saw her when she was stressed and very, very,
Yeah.
very stressed at that. You've got the, she's, to be fair, she's
I
lovely.
know.
She is
She
lovely.
goes walking in Pilates now.
She's all zen now. I had the,
Yeah.
all the stress. Just a last question just slipped in there. How often do you sinus wash or wash?
Um, I, so for my zygomatic patients, I usually say about once or twice a day. As I mentioned before, I do have chronic sinusitis. I've had two operations, but I still struggle immensely. If anyone knows me, like I said personally, you'll know I'm always blowing my nose. And I usually irrigate my nose in the morning and in the evening. In the morning because I've been asleep all night and it's stuffy. And in the night time, I do it because I've been in polluted air. So that's what I always just recommend to my zygomatic patients. If they want to do it more frequently, I'd say the maximum I would recommend it is about 3, 4 times a day because there's no need to be irrigating so many times through the day unless you've got massive amount of congestion or you've got a sinus issue, which then would need the dentist to check out because then this could be rhinosinusitis, which is something that needs action.
Brilliant, great. Amazing, very informative, knowledgeable. Thank you for your time. Fantastic webinar. Very useful. So loads of really, really good feedback. So that's
Thank you
great.
ever
Well
so
done.
much.
Vicky, thank you on behalf of the Ikigai community. Absolutely fantastic. Like it's a whole other world for us, but we need to know about it because we are going to get these patients through, particularly, I think, coming from abroad. So thank you for heightening awareness for us. We probably will be referring them to you, I would imagine, and your professor. But thank you so much again. Thank you, Catherine.
Thank you,
Thanks for
everybody.
answering those questions. And thank
No
you to
problem.
everybody. And yeah, stay tuned. Lots more webinars coming up, and we'll speak to you all soon. Bye now. Bye.
Bye. Bye.